Good morning.
Good morning, Lord.
Now, Mr. McIntosh, we have as our today's witness, Miss McQueen.
We do have Miss McQueen, Miss Fiona McQueen, Lord.
Good morning.
Good morning, my
Miss
lord.
McQueen.
Good morning, my
Miss
lord.
McQueen. Now, as you understand, and you've been here before, you're about to be asked questions by Mr. McIntosh. But before then, you're prepared to take the oath.
Yes, I am.
Sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much, Ms. McQueen. Again, as you perhaps recall, we take a coffee break at about half past 11. But if you want to take a break at any time, please feel free just to give me an indication and we'll take a break. Your evidence has been scheduled for the whole of the day. Whether it takes that time or not, we shall see. Now, Mr. McIntosh.
Thank you, my Lord. Miss McQueen, I wonder if I might take your full name.
Fiona Catherine McQueen.
And this is the second time you've given evidence to this inquiry.
Yes, it is.
You provided a further statement in respect to the Glasgow aspect of the inquiry. Are you willing to adopt that as part of your evidence?
Yes, I am.
Thank you. I want to just understand a few more things about your career. I understand you're currently chair of the Scottish Police Authority.
Yes.
Yes. But other than that, you're retired.
Correct.
And you were chief nursing officer until April 2021.
Yes.
Your professional background is nursing. I'd like to understand a little bit more about what your professional interests were in nursing before you reached the roles in government. Do you have a particular area of nursing professionalism that started you off, or which you've maintained an expertise?
So there was no particular area other than nurse leadership and patient safety, although earlier on in my career, patient safety wasn't terminology we used, but we talked about quality of care. So I was interested in leadership of the profession and how the profession could impact on better outcomes for patients.
Okay. Now, if we can go to your statement to paragraph 9, which is on page 74 of the statement, you discuss the CNO directorate within the Directorate of Health and Social Care, and you've given us 5 bullet points to describe the responsibilities, or some of the responsibilities, of the CNO Directorate in paragraph 9 on page 74. What I want to understand a little bit is about what's been described, I think, elsewhere in your statement as the HAR unit. Well, firstly, what's the sort of scale of that unit? How many people are involved, approximately? Or when you were involved, anyway?
So when I was involved in it, it wasn't a large unit, but it didn't mean it didn't have big impact. So there would be an infection control nurse and an infection control doctor who were seconded in from the NHS, so specialists. And then there would be maybe 3 or 4 policy advisors who
And
were
they'd be career civil servants?
career civil servants, yes.
So we're looking at sort of less than half a dozen?
Yes.
And had that sort of size been relatively consistent in those years? This is obviously before the pandemic.
Yes, I think so. For the Queen Elizabeth inquiry, we needed to supplement that with additional staff, but for the oversight board. But in terms of the day-to-day HAI policy unit, it was reasonably consistent.
And if we look at the whole of the CNO Directorate, what sort of scale in terms of headcount is that?
So I'm sorry, but I don't remember, but maybe 60 or 70.
Yeah, I mean, I'm just really working out how much of your work is dealing with the HAI unit as a proportion of what you were doing before the oversight board.
So it was a small proportion, but it had big impact. So even before the oversight board, it would be something, because it was critical for patient safety, there would be reports in when boards reported into Health Protection Scotland, as it was then, it moved in to become NHSR High later on in my tenure, then boards would report in infections and whether they were green, amber or red. And we would then, the purpose of that was to keep us notified, but also so that I could be content that it was being dealt with properly.
When you say dealt with, do you mean reported properly?
No, I mean the actual overall management of the incident and the infection, because Health Protection Scotland would have been either round the table or would have received reports from the boards on infection incidents. They would give professional advice. So the professional advice I had extended to that from Health Protection Scotland. It was not only the policy unit. So Health Protection Scotland, when they reported, because it would be onward transmission to us, they would tell us whether or not they thought additional work was needed or whether they were content that the ongoing areas of investigation and management that the boards were doing was satisfactory.
To an outsider, it looks like there's effectively three layers. There's the actual IPC team in the hospital, there's RHI providing advice and support, and then there's the HI unit. To what extent are you seeking assurance that things are being well run through this process?
All the time. That was the purpose. And primarily that would come from Health Protection Scotland, because they would have the close connection with boards and with the IMTs and have a much greater knowledge. And they would also then have other specialists and experts that they could draw on to come to their conclusion. And on the whole, incidents were managed very effectively right across Scotland.
Well, were you being reported both the good cases of management and, if there were any, the bad cases of management?
Well, typically anything that needed additional attention, when Health Protection Scotland was suggesting carrying out perhaps additional audit or having a different specialist in to give advice or taking a different approach, almost always boards would accept that and do it. So by the time it got to me, any issues that had been highlighted had been resolved.
I suppose one way of asking that is it an exceptions reporting system in that RHI, HPS are coming to you when something isn't working to their satisfaction, or are they reporting routinely for every board? For example, you know that each month there have been that many infections in that board and it's been well done, or are you just getting the bad news, as it were?
No, the green, those that had been assessed green wouldn't come up to the policy unit. The amber and red would.
So every amber and red comes to you, right? And how is you as Chief Nursing Officer, how are you absorbing that information? What's the sort of process that you had in your routine to start?
So I was absolutely accountable for that system and process, but I had a very good team who would deal with that. So I had every confidence in Health Protection Scotland for their oversight and their working with boards, and I had every confidence in the policy team that they had effective relationships with Health Protection Scotland. On the whole, they had effective relationships with board teams as well. So I was taking advice rather than me making any.
No, I understand that. What I meant was, how are you receiving that information? Are you receiving sort of a weekly briefing in a manner that is accessible to a senior leadership nurse? Doesn't matter what his or her specialism is, or is there some other mechanism of briefing you?
No. So when I first arrived, the briefings that would come up from Health Protection Scotland we would then brief to the Cabinet Secretary.
Right.
And that would just come as and when. So if we had 2 on a Monday morning, that would go up, assuming it wasn't urgent.
Yes.
That would go up maybe Tuesday afternoon, and then another 4 on Wednesday morning, and that would go up. So what we then decided that we would do is we would have a weekly briefing, and we would then on a Friday have a comprehensive overview of the reports that had been received. If there had been anything that was particularly concerning, that would have been reported out of sequence. So on the whole, we got into a rhythm of the HAI policy unit would look at having a weekly review to brief the Cabinet Secretary and obviously myself.
And so when that briefing to Cabinet Secretary went, is it going, as it were, you're looking at it first to go, yeah, that's what we need to brief, and then are you going doing the briefing, or are the professionals going?
it would be a written briefing.
Written briefing. To what extent, I mean, this is obviously, at one level, it's a truism, but to what extent do you have to adjust the method by which you brief to the interests and temperaments of your cabinet secretaries? Is that something that you're doing as well, or?
Yes, you would check with the cabinet secretary what they wanted to know when and how they would have that. So when we went from the ad hoc as and when briefing, it was Ms Robson at the time, we put forward a suggestion to her that actually it might be more effective if we carried out a weekly briefing. And on that dialogue, we reassured her that anything of urgency, we would brief right away. And
Because presumably she doesn't want to hear about it from some other source before the briefing.
Exactly. So the no surprises piece, we would want to keep that as best we could for her. And then if there was perhaps something in the Cabinet Secretary's constituency, they might be a bit more alert to it. Or if there was, a serious infection, perhaps with either death or other morbidity that would be associated with it.
You might brief those out of the week sequence,
yeah.
Right? And to what extent was there any route by which boards could come directly to the HAI unit? You've got a process which you've described of going from board to RHI, RHI to you and your team, and from you and your team to the Cabinet Secretary. We've heard from Miss Imrie about how there is a series of stakeholder groups that RHI run around the National Infection Control Manual and evidence and how they develop their practice. But is there any mechanism, and we also know that the Director General of Health and Social Care has a regular meeting with chief executives of all the health boards. Was there any system by which your team were, for example, meeting with the infection control managers or the HI leads or anything like that on operation? So
when I first took up post, there was a series of meetings with the HI policy team with other networks across Scotland. The advice I received from the policy team was that they weren't the most effective.
So just what we're going, what other networks are we talking about here?
So microbiology, infection control nurses, infection control managers.
Right.
So all within the HI sphere. And they advised that they weren't productive, they weren't getting good outcomes from these meetings, and these meetings stopped.
And when would that have been roughly?
That would have maybe been 2016 or so. On reflection, I think we should have worked harder at improving these meetings rather than stopping them.
Was there, because we know from the Vale of Leavel inquiry that one of the recommendations was that all health boards should have an infection control manager.
Yes.
And Mr. Walsh was very keen to explain to us how he'd taken on that role and how he thought it was so important. I don't know whether all the other boards do that, but was there a process by which the HI team was in regular dialogue with those people across all the boards?
When needed.
But not a sort of structured process?
Not for a period of time that I was CNO.
And do you know if it's happened since you came in, you left?
I think it possibly has, but I couldn't be certain. Okay. But NHS RHI would do that.
No, I mean, I know they do, but I just don't work out what you do. I want to look at what your understanding is of the sort of roots, purpose and status of the National Infection Control Manual. So from your point of view, who is producing it and controlling it?
So if I may,
the
National Infection Prevention Control Manual is produced by NHS RHI.
And that's their job?
That is their job. But if I may, and I know you'll know this, but NHS RHI and Health Protection Scotland before them, they are the organisation within Scotland who have the expertise and the specialist knowledge and access to, whether it's experts in the World Health Organisation or the European ECDC. So they have the professional knowledge and expertise on many areas, but in this area, in healthcare associated infection. And they, in 2012, the CNO, I think, launched the first National Infection Prevention Control Manual. And the purpose of it is to reduce HAI, to improve education and training, to look at research and essentially improve patient safety. So that's its purpose. and they are responsible and accountable for its production. And they do that in many ways.
And they've explained that to us. I suppose the only follow-on question then is, to what extent does the HAI unit have any input into that?
It has. They're part of there are a number of groups that that HPS and NHS RHI have, and the policy team would be part of that. There's a very, very close working relationship between the policy team and RHI.
But it's whatever the relationship, it's their document, not your document.
Correct.
Right. Now, I think it might be helpful to understand your understanding of the purpose of the reporting system for HIs in Chapter 3 of the National Infection Prevention Control Manual. What do you see its purpose is?
So, good and effective infection prevention control systems are essential for safety and welfare of patients and staff. And the reporting system has been developed as an iterative process over the decades, usually learning from incidents. But now that NHS RHI...
Could you lift your voice a little bit?
Yes, my hearing is not what it was.
My apologies.
And a slightly lower voice and a faster delivery does make it a little bit more difficult. So if I could encourage you maybe a little louder and a little slower.
Yes, thank you.
Mr. Matt.
Yeah, so you've described what the importance of good infection control management is, but reporting, why is that something that is a good, as it were?
Because there's opportunities for learning in terms of if you report one incident, then that on itself may tell you nothing. But if you report every incident and you're looking at a series of incidents, then it allows you to draw comparisons. It allows you to decide whether or not there's any interrelationship, are there any common patterns? And also it's important for good governance in NHS boards so that there can be appropriate and proportionate scrutiny from NHS board committee structures.
If it was to be the case that a board was considered not to be reporting in compliance with Chapter 3 of the National Infection Control Manual, what would be the consequences of that for general patient safety across the NHS?
So if boards are not reporting, then they're missing opportunities for learning, for looking at consistency, looking at underlying factors. It suggests to me there's a closed mindset with regards to what's happening in the wider infection prevention control system within their organisation. So I think there's a risk that patient safety could be compromised.
Can you expand on what you mean by a closed mindset? So
infection prevention control is a very complex area, and you'll have heard right across this from many, many specialists. And it's important when you have an infection, and unfortunately, no matter how much people wish it were not so, at the moment, hospital-acquired infection and healthcare-acquired infection is a phenomenon. And
Sorry, I missed that last word. But
I do apologise, sir.
No, it's very difficult. And if we were having a conversation, I wouldn't be having this problem. But I'm trying to not make necessarily a verbatim note, but to get the important points. So again, if I could encourage slightly louder, slightly slower. Now, what I got was at the moment, and then you referred to...
I think you mentioned the word phenomena.
I did.
Yes.
So hospital-acquired and healthcare-acquired infections are a phenomenon within modern healthcare practice. And the importance of having good, effective infection prevention and control procedures cannot be overstated, because that then improves patient safety. And I've now forgotten the question.
No, I think that's part of the answer, part of the question answered, but I think there's a supplementary. You mentioned when I asked you what your interests professionally were, your interest in patient safety. Now, I took from the way you expressed that, it was at a higher level than simply infection prevention control. Am I right to think that?
So it was at a higher level, but there are many aspects of professional practice that make up a safe environment for patients, both psychological safety and physical safety. And when you asked me about making sure you don't have a closed mindset, for infection prevention and control, if one assumes that the infection is inevitable because it's one of these things, or if one assumes that it's only an infection that the patient has infected themselves, then you're not giving due consideration to all possibilities. And with infection prevention and control, one needs to start wide and then rule out, rather than start from a narrow assumption that a catheter-associated infection, for instance, was the patient had contaminated themselves.
Can I just explore those two concepts, that of inevitability and the patients contaminate themselves? Because I wouldn't want to put words into your mouth or thoughts into your mouth or someone else to do it later. We've heard some evidence about the debate around whether particular infections are from colonized patients or from the hospital environment or from clinical care or whatever. Is that debate you're referring to?
Yes, because if you assume it's one thing or the other, then you're not necessarily getting to the truth. One has to consider all aspects and then rule out as you go through the incident management process.
You rule out with evidence.
Yes. If you don't always have evidence.
Well, I was going to come to that in a moment, but if the other one you mentioned was the idea of inevitability, and we've come across that in different contexts. Before I put those to you, what do you mean by inevitability?
I think there's a number of factors. You can have the patient's own condition. If the patient is immunocompromised, then they're going to be more vulnerable to day-to-day infection. If you have human factors within the healthcare system, whereby there may be transmission by a member of staff from patient to patient, or if you have environmental factors where there's contamination either of the ventilation system or the water system. And areas such as hospital buildings, if you look at single rooms compared to the old Nightingale wards, ought to have significantly less hospital-acquired infection because patients are nursed and cared for within their own single room rather than in a 20-bedded complex. So there's always going to be risk. And that's why the National Infection Prevention and Control Manual is so important, that you put transmission-based precautions in place. You have standardised infection control procedures and constantly have to be vigilant that these are as most effective as possible. And that's why when you have incidents, you need to learn from them and recognise where you can make improvement. So my interest, looking back to one of your earlier questions of what was I interested in, was it more high-level strategic? It was both. It was from the patient to the board in terms of how you can actually have clinical leadership that impacts on a daily basis with patient safety.
So in order to not put words in your mouth, I'm going to use a slightly different example and check I've understood this correctly. So if we think about the issue that I think was a big issue of patients falling out of bed, I mean, that was an issue, still is to some extent, but it was an issue 10, 15 years ago. Have I got that memory right?
Yes, patient falls are always problematic within an institution.
But you would be saying that you shouldn't take the view that it's inevitable that patients will fall because they're elderly and frail or confused, and you shouldn't assume that it's their fault because they decide to get out of bed and go for a glass of water, when actually you might be better thinking about the design of the bed or the provision of water to the patient. That's
absolutely correct. And I think in some areas of healthcare practice, it's easier to make that distinction of inevitability. If you walk into a GP surgery, you would be very surprised if you came out with the wrong limb removed, because that just doesn't happen. Whereas in some areas of practice, whether it's obstetrics or in hemato-oncology, these procedures run a higher risk of mortality and morbidity, and it is not quite as easy to determine what was preventable and what wasn't, but one should always aim to reduce to the absolute minimum the harm that's been caused to patients.
How does the what's the effect of the question of blame and who's to blame, which obviously is a naturally human response to things going wrong? How does that affect the process of learning and improving in terms of patient safety? Does it have an impact?
It has a huge impact. You cannot learn and improve and provide as safe care as you want to if there is a culture of blame. And that can be a real problem because people often want retribution. It's perhaps human nature to look at whose fault it was. So a psychologically safe culture within healthcare is so important.
Now, what do you mean by a psychological? Because we hear that a lot in modern discourse, a safe space and things. What do you mean by a psychologically safe culture?
So what I mean is, and I think Sir Robert Francis has spoken up about speaking out, what I mean is the opportunity for teams to be able to reflect, discuss, be a learning organisation, and that means calling out poor practice. It means being able to raise concerns and know that these concerns are going to be treated appropriately, professionally, and respectfully. And that takes a lot of work. It takes work to build a team. It takes work to look at learning. And it also means organisations have to be able to hear things that they don't want to hear.
And when you say an organisation has to be able to hear, are you able to help us by examples of how an organisation can demonstrate that it wants to hear, and indeed things it can do that can have the opposite effect?
So things that it can do to have the opposite effect would be to blame people, would be to minimise, would be to ridicule, would be to ignore. Things they can do to encourage is essentially organisational development work to put patient safety at the heart of what it's doing. And the patient safety programme in Scotland did quite a lot of this along quite a lot of areas, but I think in some areas haven't been taken forwards. So
when you say area, do you mean areas of practice?
Both areas of practice, and I think some health boards have taken it on in a fuller way than others, but some specialties also haven't, because it would have meant perhaps a shift in practice in the way they do things.
I'm sure we'll come back to that, but what I want to do now is to move on to your statement. I think you addressed this actually, it's quite a long way in paragraph 33, which is on, well, actually it's paragraph 32 on page 82. We asked you the details of your involvement in a list of things, and perhaps unsurprising given your date of appointment, which it was November 2014 that you became Chief Nursing Officer.
Yes.
So I obviously, in one sense, am not surprised. If we go over the page, you explain you didn't have any involvement with these matters. If we go back to the list, what I want to do is understand, since you arrived in the post just before the commissioning water tests were being carried out, about 6 weeks before handover, I want to explore what you might have been told about things. Conscious that the answer might be nothing at all, but I still need to put things to you. So you've taken over in November 2014, and you have the responsibility of the HAI unit. And if we go back to your statement on paragraph, well, we won't go back there yet, but if we just think about your responsibility as Chief Nurse, did you have any awareness in the summer of 2015 of the short period in which the adult bone marrow treatment ward was in Ward 4B before it returned to the Beatson, and that story and that event? Did you have any awareness of that?
I may have, but I genuinely don't remember. And when there's a new build and a commissioning of a new build, there are often hiccups. So even if I had known, I'm not sure I would have necessarily been alerted in a negative way about it, but I don't recall, or if I did, it was peripheral knowledge that I accepted as a matter of fact rather than a matter of concern.
I want to just look at, I mean, I think the answer may be the same for the next question, but I want to just put something to you. I'll make sure I just remembered what it is before I do that. There is an email that we were putting to earlier witnesses, we were asked to, from the sector ICD for South Sector to the Infection Control Manager on the 26th of June 2015, which is Bundle 12, Document 25, page 225. And since some of these do mention or touch on healthcare-acquired infections, or at least the potential for them, I just should press you on whether in 15 you and your colleagues had any awareness of these being even a potential issue. I'm thinking of Legionella and water testing of the system. Is that something that came across the team's desk in 15?
So I can't speak for the team,
Right.
But it didn't come across my desk. And with hindsight, it certainly is alarming that a hospital would be occupied and the infection control doctors continue to have concerns. But equally, a big hospital like the Queen Elizabeth so it's inevitability, it was always going to have snagging. And it's just a question of, was it routine snagging or were there serious defects that were causing concerns for the infection control doctor?
If we go back to your statement, page 83, question, paragraph 33, in your answer, 83, sorry, you explain the delivery of major, in the third line, in any event, the delivery of major healthcare facilities is, as far as the Scottish Government involved, the principal responsibility of the Scottish Health Finance Directorate, not the CNO Directorate. Mike Baxter, a better place to address the inquiry questions. Now, we did address them, Mr. Baxter, but I think I've got his evidence right in my head that one of the things he wants me to hear is that his team and his system is not set up to assess, at least it wasn't then, not set up to assess technical matters. No. They are finance people, whatever the involvement of a few people in their SIG who have other experiences. Now, I'm conscious that we now have an NHS Assure, and we will discuss that with Ms. Critchley on Wednesday, and what it can do and maybe what it can't do. But thinking back to this period, is it a fair criticism to suggest that the team that were responsible for the commissioning delivery of the hospital from the Scottish Government's end, and there's a quotation mark around responsible there, didn't probably have access to the critical technical skills that might have existed elsewhere within the Director General system, including perhaps your team?
I don't think it would have been appropriate for policy civil servants to be taking a view on competence of a building. I think that would be delegated to the NHS board, and it would be for them to oversee and manage the contract, ensuring they had appropriate access to professional advice.
Because one of the evidence we had yesterday from Mr. Calderwood is that in the months before handover, he and his team went to Australia to look at experience in another multiplex hospital commissioning. And it occurred to me overnight, in fact, that I'm sure that was very interesting, but the regulations are different in Australia. And is that perhaps a slight oversight, because you are effectively relying on a health board asking for help? When you, the Scottish Government, are relying on a health board asking for help, and more importantly, knowing that it needs to ask for help and not doing things like failing to validate or getting the wrong source of advice. There's no check. Would you accept that there's a weakness in the system, at least there was back then, of a slight level of trust of health boards and no check? So
I don't think it's as blunt as you're suggesting. It was trust with no checks. The board and the board chief executive were accountable for delivering on that big construction project. I think you've heard from other witnesses about the transition from PFI into public sector capital spend and the different funding streams and the different responsibilities and accountabilities for technical advice and where that sits. So I think there was a vulnerability as we moved from system to system to make sure that the appropriate checks and balances were being taken. But I see no reason for a project of this size not to have had the appropriate checks and balances put in place.
Okay. Want to move on to, in fact, the next section, interactions with the infection prevention control team. And now, I felt when I was reading the next 4 paragraphs that I should probably take from this that your memory of this isn't as perhaps as vivid as I would like it to be. Is that a fair criticism? What I wanted to do was look at the incident you describe in NICU in paragraph 34. Now, I should say, my lord, that NICU is in the retained estate, and in the closing statement from counsel to the inquiry last year, we made it clear that NICU itself therefore falls out with the remit of the inquiry. The reason I'm asking these questions is because I'm interested in HI reporting on term of reference 9, and I felt it's important that I should make that overtly clear. There's an S-bar you refer to, bundle 3, document 3, page 15. And so this is produced presumably by HPS?
Yes.
Yes. And it follows the invocation of the National Support Framework.
Yes.
And this is stage 2 of that framework.
Yes.
Right. Now, I wonder if we also look at the GGC S-bar. Well, before we do that, let's stay with this. In your statement, if you look at paragraph 36 on page 84, we asked you, 84 please, thank you. We asked you of your impressions about the GGC IPC team in 2015, and were you aware of tensions or lack of clarity related to role and decision-making, relationship difficulties between team members, issues of record-keeping, a culture of bullying, and the attitude of senior management to IPC issues? And you said you weren't aware of such tensions. So when you then convened a meeting with GGC IPC, so who in the IPC team did you meet with?
So I don't recall everyone who was there, and I did ask the inquiry support team in the civil service to see if they could find notes, and that couldn't be found because a note would have been taken of that meeting, but possibly with document retention, because at that time we had not anticipated a public inquiry. So I met with the executive lead for HAI, who was Dr. Armstrong, the medical director.
Yes.
And she brought, I suspect she brought the infection control manager and infection control nurse, at least with her. I can't remember if she brought a microbiologist with her.
Might she have brought Professor Williams, who was then the lead ICD?
She may have, but I don't recall.
Remember. But she didn't tell you about sector ICD's remitting office and writing to her complaining about building safety and culture?
No, she did not.
What I want to do is, you've referred us to, as it were, HPS's S-bar, but there's also a GGC S-bar, which is bundle 4, document 8, page 26. Now, it bears to be addressed to the HI policy unit. And now that we put it on your document list, is this something you have any memory of seeing? And we can go over the page just to sort of jog your memory a bit more. And the final page is perhaps the relevant bit. 4th page, sorry, page 29. It's longer than I remember, page 30. And then the discussion about a meeting chaired by the CNO at St Andrew's House. Is that where you recollect the meeting taking place?
Yes.
And a further meeting between HPS and GGC, and this discussion of various lessons to be learned. And then there was to be a consensus group facilitated by HPS, chaired by Dr. Inkster. And that seems to be a national group, the consensus group. Would that be a right read of that? Right. Now, if we go back to the first page of that document, page 26, This version of this SBAR describes the number of serratia cases and gives a little bit more detail. And what I'm wondering is, can you help us whether at the time this was reported and you got involved and the framework was invoked, whether this incident would have been under control?
So by the time Health Protection Scotland had been in working with Greater Glasgow and Clyde, I was content that appropriate control measures had been put in place.
And so what was the issue about reporting that seems to be touched on here?
I think that the issue and the purpose of the meeting I had with them, I thought was a single issue meeting. And that was Greater Glasgow and Clyde were not reporting in a manner that I would expect them to do. And I was articulating to them the fact that that's what I would expect. And for me to have a meeting, to have that dialogue with a board, my own team and Health Protection Scotland had probably exhausted all mechanisms to persuade Greater Glasgow and Clyde to change the reporting system and the reporting mechanism.
So what was, just to grasp a word, what was wrong, as it were, with their reporting approach or mechanism before the meeting?
They weren't reporting, is what was wrong. They weren't following the guidance appropriately in the Infection Prevention Control Manual, and they were rating some of their incidents at a slightly different, at a lower level than perhaps Health Protection Scotland should have.
Because back then, if you rated a green, you didn't report it.
Yes.
And should we latch on that as the particular issue, or are there any other issues?
No, so at that time, the only issue I had was Glasgow not reporting appropriately.
And that's because they, to some degree, were down rating. Or am I putting words in your mouth now?
You are putting words
right. Well, can you
in my mouth.
perhaps you can expand on what you mean, because I'm grasping for depth to that sentence.
So they weren't reporting in a manner that was consistent with what was expected for boards across Scotland. I believe that they believed they were interpreting it appropriately. I don't think they were saying, we think this should be amber, we'll just make it green, so we'll report it. So they weren't downgrading incidents. It was the calibration that they had of incidents was different from the rest of Scotland.
That calibration, or that miscalibration, is this a scenario where that was found to have been written down in a policy, or was it, effectively, as far as you understood, not written down in the policy?
I think it was custom and practice.
Custom and practice, right. We go back to your statement, page 84. In this large paragraph on paragraph 36, you say, it's about halfway down to the word outlined on the left-hand side. The sentence goes, at the meeting, we clarified how incidents and outbreaks should be reported. Dr. Armstrong attended the meeting supported by her colleagues who at that time acted as the IPC leads for GGC. I cannot recollect the names of everyone who attended the meeting due to the passage of time. However, the main issue appeared to be that NHS GGC had not been reporting incidents. Now, there seems to be a plural there. Can you help us about, to some extent, how many incidents and whether they are within this serratia SBAR?
It was wider than serratia.
It was wider than serratia, right?
It was something that my team had an increasing awareness of, partly through ongoing relationships they would have with Greater Glasgow and Clyde colleagues, but probably more through Health Protection Scotland. When an incident was reported, then they would look back and find there had been other incidents that hadn't been reported. So that, no, it was wider than serratia.
Yes, because if an HPS nurse consultant goes to a meeting, an IMT, and they start hearing history, and then, well, why wasn't that reported? It's effectively that process.
That's correct.
Right. And you've mentioned in the next sentence, there's no suggestion that there was a deliberate withholding of information. To what extent are you aware whether GGC adjusted their approach following the meeting?
I think they did adjust the report, their approach following the meeting, but I think there was a deep-seated behaviour within Greater Glasgow and Clyde, and we've seen that as the years progressed, that meant it was difficult for changes to be made. So I think they intended to, and the letter that was issued, the director's letter that was issued, instructing people to report.
And that was a all Scotland letter? It
was an all Scotland letter, and the advice I had received from my team was the only way that we'll know that we get all incidents reported is if we ask for greens to be reported as well. And that's what we did.
If it's your view that there was a custom and practice, not a written formal policy, are there any other steps, looking back out, to use the word of the week with the benefit of hindsight, that you could look back on to think, well, we could have done something else at the stage of issuing that letter to make sure any change was long-term and was really bedded in?
I think that's difficult because that seemed to be, on the face of it to me, the only issue was the calibration of what was either determined as an incident, because an infection doesn't necessarily have to be an incident or an outbreak. And that relies on professional evaluative judgment. And members of the infection control team in Greater Glasgow and Clyde were more than capable of doing that. So on the basis you don't know what you don't know, it was always going to be difficult, and you would rely on the team culture and the team commitment to making these reports. So at that time, I don't think there were other indicators that would have suggested to me I needed to do anything further.
And in fact, we see in a Board Infection Control Committee minute on the 27th of July 2015, which is bundle 13, document 33 at page 256 is the start of the minute. And then if we go to Dr. Armstrong in the chair, and if we then go to item 6.6, which is page 260, we see a mandatory HI requirement is the heading, and the Scottish Government issued a letter regarding healthcare associated infections, antimicrobial resistant AMR policy requirements, and the mandatory requirements required to be adopted, implemented in all the healthcare settings. Now, what I'm wondering is, so of course, in one sense, it's only a minute. It's a minute of a meeting 10 years ago. But did you have an opportunity looking at this document when we put it on your document list?
Yes.
Do you have any comment on what's appears to have been discussed at that meeting following the issue of your letter?
No. Could you point me to
so
something?
If we look at the letter, what it doesn't say, that a Scottish Government Chief Nursing Officer came to us and said, we've been under-reporting due to customer practice grading things amber, green when we should have graded them amber. And I recognise that's a quite pejorative way of summarising what you just said, but it doesn't say anything like that. Now, of course, it may have been discussed in the meeting and not minuted. It may have been discussed elsewhere, but I'm wondering whether you feel that when you go to a health board and say what you said, you'd expect things like the Board Infection Control Committee to notice.
Yes, I would, and I would expect that to have been reported by Dr. Armstrong. It may have been she reported it at different times. It may have been reported
elsewhere, but in this meeting it's not there. If we go back to your statement, paragraph 37. you say failure to follow the HI reporting procedures set out in NIPCM was highly unusual during my time as CNO. So let's explore that. So if we start where we still are, so in 2015, you've only been in post a year. Were there any other health boards who were being challenged for this sort of behaviour?
Not to my knowledge. If they had been challenged by Health Protection Scotland finding an area where they hadn't reported, then, as I say in my statement, that would have been resolved very quickly.
Yes.
So, no, to my certain knowledge, it was only Greater Glasgow and Clyde.
Can we infer by the fact that in this occasion you got involved that it wasn't being managed to the satisfaction of HPS?
Yes, I think both HPS and the policy team felt they had done as much as they could and they needed me to intervene.
And so the reference in the second half of this paragraph, occasionally GGC reported infection as green, which they reported as amber. This was addressed by HPS without formal intervention from me or the HI unit. Is that talking about a different occasion from the one that's talked about in the previous paragraph?
Yes.
So are you saying that you're aware of other occasions which HPS dealt with informally?
Yes.
Before and since?
Yes.
Right. How would you react to the suggestion that once this has happened, you and to some extent HPS should be a little bit more alert to any suggestion that GGC wasn't reporting compliance and not simply left it as an informal follow-up for HPS, but escalated in the future in subsequent events, which, according to this, you've dealt with not you, the audit system has dealt with informally?
I think it's a reasonable question, and there is something about NHS boards being accountable for their own practice. And Dr. Armstrong was an executive lead, and she was committing to making sure that change was made. It would be something that Health Protection Scotland would come across in terms of the way that they came across it in the first place, where they were involved in an IMT and previous infections had been reported. So I think it would be informed in day-to-day business rather than a formal auditing or monitoring.
This is perhaps a question for recommendations, but do you think that we've heard lots of examples of HPS, RHI team members going to meetings, and sometimes it's been a great success, and sometimes not so much a success. And we've had examples of, which we'll come to, of differences of opinion between GGC's IPC team and RHI. But in this case, you would assume that the invocation of the framework would have been reported up through the board's government structures. Do you see any value in the system giving you the ability as Chief Nursing Officer, or potentially RHI as its ability itself, to send a report to the board that says, you wouldn't have to do this, it's optional, give you the power to effectively force your report onto their agenda so that you can be absolutely sure that the accountable board members know about the issue? Do you see that as a valuable tool in the future?
So I think I've thought about it quite a lot as I've watched the inquiry unfold. And I do think we need more effective measures that can provide assurance to the public, to boards, to government, and the clarity and openness and transparency of that reporting, I think, is important. I don't think it would be for a civil servant to do that, but there may well be something for NHS RHI to, their remit would have to change, but I do think there is an opportunity for RHI to have a greater role in providing open and transparent management of infection prevention and control.
I just want to pick up the thing about remark about the civil servant. I take what you're saying from that is you don't think that the Chief Nursing Officer and her HAI unit should be pushing things onto the agenda of the health boards. It should either be RHI or do it, or I suppose ultimately the Minister.
And I think so, because the CNO and the policy unit aren't set up to have that level of expertise. The expertise lies within RHI.
The other question is, we had some evidence from Miss Imrie, who came back, and she, last Friday, I asked her about whether RHI should have a more an audit investigatory role. And I think it would be a broad summary to say that she was worried that would change the nature of the working relationship. If there was a system that enabled RHI to elect to, perhaps it's chief executive level or something, to force a report onto the board agenda for a health board, perhaps only to be used when you're a bit worried that they're not getting the message, would that have a chilling effect of the sort that Ms. Imrie is talking about? Do you feel that's a fear?
I think the chilling effect of suppressing even further people reporting concerns is a concern. However, just because RHI had that authority doesn't mean to say they would have to use it. And I do think there's something for Healthcare Improvement Scotland, plus or minus RHI, depending on where the expertise lies, for doing that. As I say, I think the functions of RHI would have to be changed. And I heard what Laura had said, and I understand her concern. But I think fundamentally we need to find, and we've built on it over the decades. So this would be a natural iteration of how we would manage to put systems and processes in place that would support boards from a non-executive point of view, from a scrutiny point of view, to ensure that the care and delivery, in this case in infection prevention and control, was as safe as it possibly could be.
I suppose this is, since you're retired, I feel like I can ask the question. It's been suggested, I think, by at least one core participant in written submissions, and I think others have mentioned it, the idea that what we actually need here is some form of formal inspectorate of IPC teams, maybe HIS, maybe a new agency. And I know there's a strong view that we've got enough agencies. But from your point of view, given what we're about to keep talking about, the rest of this, your evidence, do you feel there's any value in having some formal, almost like an IPC version of Audit Scotland out there, watching health boards?
I think I would argue it perhaps should be wider than IPC. So if you look at the way external auditors or Audit Scotland gives a board a clean bill of financial health, I think there are opportunities for other agencies, whether it's RHI or Healthcare Improvement Scotland, to give a clean bill of health in terms of patient safety, which would include organisational culture. I think people are right in terms of saying there's a lot of agencies, but it's maybe a time to review what agencies do and what we're needing them to do now as things have progressed. The Healthcare Environment Inspectorate was created after Lord McQueen reported in terms of the Vale of Leven. So the hospital cleanliness inspections carried out by his, and not a derivative of that, the derivative was the Healthcare Environment Inspectorate.
Yeah, and it got merged, and that's what organisations do.
So there has, but that was looking at cleanliness. It wasn't actually looking at professional practice of IPC. So it would almost be a quasi-regulation or accreditation of IPC. And that would perhaps be worth being considered, but considered alongside other agencies, and the burden of oversight and inspection needs to be something that is meaningful and worthwhile and can make a difference.
I suppose the question that occurs to me is there are lots of health boards in Scotland, a huge range of sizes, and all of them might take the view that a accreditation or inspectorate system, perhaps run by HIS or something like that, might be an administrative burden they're ill-equipped to afford to support. And you're nodding. Remember the transcript person. So if you agree with me, say yes. Say yes. do you have any thoughts about how one would devise such a accreditation or inspectorate system so that it didn't create a burden in the way that, for sometimes the English school inspectorate system is characterised as a burden on schools? Have you any thoughts about how that might be done?
So I agree that it could be seen as both an administrative burden, a time burden, a financial burden. But there's no doubt in my mind that safe and effective patient care, which ultimately needs to have effective IPC processes, has to be at the aim of what care is being delivered and is cost effective. So if you have improvements, if you have safe care, if you reduce infection, that is going to be cost effective. So I think anything that was being recommended would need some deep thought and reflection. And at the heart of it, it would be what would make a practical, tangible difference and what evidence of effectiveness would be needed for that. I think there's a temptation to add another layer onto what's already happening. I think there's a temptation to then start, well, we'll have light touch and it will be self-reporting. And we've already discussed this morning that self-reporting sometimes isn't the most effective thing to do. So anything that we had, I think, needs to be looked at in the context of other arrangements. And there's no doubt having professional standards, having an accreditation and inspection model, whether it's peer review going forwards, can be an effective way to improve outcomes.
Thank you. I want to just, you mentioned self-reporting and issues arising. I put on your document list an exchange of letters between the current Director General and Professor Gardner at GGC, and in August, and a subsequent letter between Ms. Morgan at NSS and Professor Gardner to Ms. Lamb. Do you recollect reading those three?
I do.
Yeah. Having read them and given what how do you respond to the what appears to be the evidence that there remain concerns about GGC's reporting of HAIs?
I'm incredibly disappointed.
Sorry, I missed that answer.
Incredibly disappointed, my lord.
Thank you.
So, what is it that disappoints you?
That in 2015, we had an open dialogue about reporting of infections. We had a series of issues within infection prevention and control within Greater Glasgow and Clyde over the following 5-6 years. The board were escalated to level 4 for problems with infection prevention and control. And yet still things have not been resolved. And that bothers me because I worry about the quality of care that's being delivered if safe and effective infection prevention and control mechanisms are not in place in one of our biggest boards in Scotland.
I'm going to come back to that topic at the end. What I want to do is to just make some progress on the narrative, and to move to the water incident. And you picked that up in paragraph 38 at the bottom of this page. Well, can we go back to 84, please? Sorry. You report in 2018, GGC were required to report potential healthcare-associated infections to RHI, who would in turn make colleagues in the CNO Directorate aware, over the page, and that water contamination can be complex. Is that just a sort of a narrative structure? You're not actually saying there was a particular extra direction or anything going on at that point?
That's correct.
Yes. You provided a timeline, which was prepared by the Scottish Government in respect to one of our Section 21s, and so which is when we make a statutory request to an organisation to provide information. And this timeline is bundle 52, volume 1, document 37, page 609. And just to, if we go on 2 pages, 1 page, sorry, to page 610, we reach the timeline. Now, I'm going to try and run the risk of further confusing the situation by now using 2 documents at once. So both your statement and this timeline. If we go to the timeline on page 613, we see March 2018, top left-hand corner. If we go back to your statement on page 85 of the same bundle, at paragraph 40, we see you making reference to the 1st of March. And we have a letter that seems to, on email rather, which seems to be relevant at this point, which is bundle 52, volume 8, document 2, page 39. So it's an email from Jan Liddell, who I assume effectively works for you.
Yes.
Yes. To Dr. Armstrong, copying in. I get the impression that most of the CC line there is civil servants.
They were all civil servants.
Yes. And this is on the 20th of March. And you're passing on them. Well, what's the purpose of this email?
I think it was essentially advising Jennifer that we were directing Health Protection Scotland to carry out the work, because there's a subtle but distinct difference. Boards can ask for support from Health Protection Scotland themselves, and that's what Greater Glasgow and Clyde did.
And they'd done that before this date?
They had.
Yes.
However, if the CNO, or in this case the Cabinet Secretary, wanted a more direct link into Health Protection Scotland, then the instruction would come from government.
What do you mean by a more direct link?
Well, they're essentially being instructed to provide, and the instruction isn't necessary for Health Protection Scotland, it's an indicator and a signal to the board that the government have asked Health Protection Scotland because they want to have confidence that everything that needs to be done is going to be done, and it takes away anything that was optional for the board, and we would be requiring them to conform to what Health Protection Scotland was doing.
So when Dr. Armstrong tells us that she asked for HPS to be involved early March, she's asking for help.
She is.
And this is you telling her she's getting help whether she wants it or not.
Yes.
But it's still just help. You're not taking over, are you?
No, not at all.
So who is responsible for making sure that the outcomes that are needed happen?
So the board are, and that's why the whole infrastructure of the NHS board, the chief executive, we've required there to be an executive lead for HAI. There's clinical governance committees, and the board then is responsible for providing the appropriate level of scrutiny and oversight, and the operational delivery is the responsibility of the chief executive to ensure that all actions taken. Now, I recognise this is a small part of delivery compared to the overall size of Greater Glasgow and Clyde, but that's ultimately the responsibility of the board, and it would be for them, and I would expect them to provide advice to the Clinical Governance Committee about Health Protection Scotland's advice to them and the fact that they had taken the advice and implemented it.
What I'm going to do is I will go return to that point, the Clinical Governance Committee, because we were looking at 2 sets of minutes of the Clinical Governance Committee with Ms. Grant, and at this precise moment I haven't got that note to me. I'm saying that partly so my colleagues next door can pull up the references for you, but after the coffee break I might take you to them. And I will ask you about what views you have on the necessary internal scrutiny governance systems are needed in a health board that's receiving this. Is this stage 2 of a framework? Or
Yes.
have I misgot confused? It is. Is it the same framework as you took it to in 2015?
Yes.
Yes, but for a different reason.
Yes, and so if the CNO, that's not necessarily unusual in a big board with a lot of patience to have the framework invoked. For a
No, I
second
mean,
time.
I get that. But just in terms of, just for our own clarity, because I don't want to get confused, on this particular occasion, if we were to go and look at the framework structure document, we would see that this stage of the framework can be invoked by the Chief Nursing Officer.
Yes.
So although in the second paragraph we see that the Cabinet Secretary is involved, technically it's you doing the invoking.
Yes.
Whereas at stage 4, it's invoked by the Director General, although we, of course, learned that Ms Freeman, who was then Cabinet Secretary, has an involvement in that process.
Yes.
Right. So as you step up through the stages, the seniority of the invoker gets more senior.
Yes, but in terms of the CNO algorithm or the support framework, that can be invoked anytime.
Now, I'm going to have to challenge you on that because I'm not convinced it is an algorithm. Can you explain why it's an algorithm?
So I think it's no longer called an algorithm. I think when it first came into existence, it was an algorithm because it was a decision-making structure
Right.
that people went through. I think it's now called the support framework.
Right. So all it means is that structure of a series of steps you can pull in certain circumstances to provide certain support or ultimately control is what some people, we used to call the algorithm, we now call the framework.
That's correct.
Because it's not actually an algorithm. Right. Okay. Now, is this all that really exists at a stage 2 with an email? There isn't a term of reference like there is for the Oversight Board in stage 4.
Yes. So the stage 2 within the escalation policy, I think is almost a red herring to this.
Right.
In terms of this would be carried out regardless of escalation.
If we just think about the moment you are arranging for this email to be sent, you've given, what are you hoping to achieve by sending this email and changing the status of HPS support?
I'm hoping to achieve a firmer grip by Greater Glasgow and Clyde on action that's necessary to be taken for safety of patients.
Does that mean that you didn't think they had a firm enough grip at the time?
It meant I wasn't sure.
You weren't sure, right. To what extent is it about providing them with more technical information than they were previously getting?
So Greater Glasgow and Clyde is a big, big health board. It has a lot of expertise and a lot of specialists within estates and within infection prevention and control. So they do already have a lot of expertise available to them. Health Protection Scotland, as it was then, have more, and they can do the legwork of searching for documents, looking at international best practice, and then translating that into day-to-day practice. So yes, it was an element of providing access to improved expertise or further expertise that would be of help.
Now, at this point in March, can you help us the extent to which you understood the nature of the problem?
I don't think, do you mean in terms of the poor commissioning of the water system?
Yes, that's all.
I think then I had no idea.
And effectively all we really have is the second paragraph there.
Yes, I think I was becoming uneasy because of over the years, the challenge of reporting or not reporting, the incidents that were being managed, and now installation and maintenance of taps.
Yes, now I see that. Is this any indication that at the time you wrote this email, you would have been aware of the Horn Tap meeting back in 2014? I mean, it would have preceded your arrival, but would you have learnt about it?
So I think so, because I think by that time the team were I think gathering momentum in terms of better understanding what was happening within Greater Glasgow and Clyde and the Queen Elizabeth building in particular. And therefore, although there wasn't anything concrete, and for me, I think the discovery of the lack of action in the DMA Canyon report was later on in the autumn. So there was nothing to suggest there was anything untoward about the commissioning of the building at this
So the only untoward thing, other than the infections and the story you've learnt about it, is the fact that by this point, someone would have brought to your attention there'd been a meeting in 2014 about the horn taps, which says what it says.
Yes.
Right. So this must be before Mr. Storer and his team find the DMA Canyon report in the data they've received.
Yes, I don't know when they found it. But
No,
yes,
but you haven't been told about it.
I hadn't been told about
Right,
it.
okay. Let's move on to to May. So paragraph 41 of your statement, page 85, you refer to a report being received from HPS regarding Cenotrophomonas bloodstream infections in wards 2A, 2B. Now, is that effectively a red or amber being reported up to you, or is it something more substantial, like a draft of the report that's published that month, written by Miss Rankin?
So it was probably both in
Right.
terms of there had been incidents reported up, and Annette Rankin was carrying out further work within Greater Glasgow and Clyde.
Because just to sort of connect things together, see if it connects. Bundle 7, document 1, page 3 is the final version of a 29-page report by Ms. Rankin, and it's the initial report of the findings of her investigation. So would we right to think that this paragraph is probably in the context of you seeing an earlier version of this?
Yes, and there would be ongoing dialogue between my policy team and Health Protection Scotland. So that would be a regular aspect, that they would be kept up to date with what was happening. And they would be briefing me on that. And it would be early briefing, not quite sure what was going to come out of the report, but alerting me to concerns.
Well, and we'll just connect this to the timeline for completeness. So we go back to the timeline, bundle 52, volume 1, but page 618. Might this be top right-hand corner, 18th and 30th of May, HPS provide a further update to Scottish Government?
Yes.
Right. It shouldn't be, whilst I'm going through, probably implying that I'm disappointed there aren't footnotes in this document. It's not an unhelpful document. I should just make that clear. You talk in the statement, page 85, second line. At that time, I was advised there was an understanding amongst some at NHSGC that the source of certain gram-negative infections in patients in Shannon was the water systems in the hospital. That understanding was not, however, universally accepted. Now, I need to understand the context of this. And if it's the case that you're not sure exactly when you heard this in the sequence of events, please tell me, because we've had evidence from a lot of the people involved in these events about who thought what when and who is claiming they thought what when. This chronologically is just after the water debrief meeting on the 15th of May, which is bundle 14, volume 2, page 211, chaired by Miss Imrie. Would you have been briefed about that taking place?
Yes.
Yeah.
Yes.
So that's the minute that Miss Imrie has been brought in from HPS to chair that. Now, the evidence that we've had from those who were there described this meeting in quite positive terms. And I don't know whether you heard anything to that effect.
No. Well, I may have, but I don't remember.
You don't remember. We then have the full incident management team report on the 6th of June, which is bundle 27, volume 5, document 19 at page 46. And if we go to page 47, we see the source of exposure, second line, contaminated water supply. The highlight immediately out of water is not a highlight, it's an indication that's the answer, according to Dr. Inkster anyway. Now, so what I need to know, going back to your statement, page 85, is who, as far as you recollect, in GGC did not accept at this date in May 18 that the source of the water was not the water system, the source of the infections was not the water systems in the hospital?
So in many aspects of healthcare, there are often a number of concepts that need to be held simultaneously.
Mm-hmm.
And in infection prevention and control, that is true. So my understanding is some of the clinicians, infection control clinicians at least, believed it was translocation. So the patients had essentially infected themselves, which is
Do you say infection control physicians or clinicians?
clinicians. Although it was the doctors that I'm referring to who believed it was translocation rather than necessarily an infection from the external environment. So I think there were a number of possibilities that needed to be ruled out. And therefore, it was difficult, I think, for Dr. Armstrong, the medical director, who would be advising the chief executive. There would be general managers, there would be senior nurses, there would be the treating clinician. There would, as far as I recall, there was not clarity and agreement that the infection necessarily was coming from the water.
I think I need to sort of press you a little bit.
Okay.
Because if we go back to the debrief meeting minute, which is 14, volume 2, page 211. We've spoken to Dr. Inkster and not that it's necessarily relevant, Professor Gibson. Spoken to Dr. Peters, but she wasn't an infection control doctor at the time. We've spoken to Professor Leonard, but he wasn't an infection control doctor at the time. We've spoken to Miss Devine, but she's not an infection control doctor. We've spoken to Dr. Armstrong, but she's not an infection control doctor. And I'm now worried that I've missed a witness because I don't recollect being told of the existence of infection control doctors who in May 18 thought, in a sense, although some people do take the view that the world's changed afterwards and we've learned more, it's fair to say that. But there's a general, I'd understood a consensus amongst the witnesses we've had who were infection control doctors in May 18, that they thought at the time it was the water. And you seem to be suggesting that out there's another infection control doctor.
So I don't know. What I'm saying is I was told there was a mix. So I didn't sit and interview infection
No, I appreciate
control doctors. And just because one wasn't employed as an infection control doctor, the microbiologists probably all have the capability of being infection control doctors. So just because they weren't designated that at the time didn't mean to say they didn't have that professional judgment.
So it might be, it could be a microbiologist you're thinking of.
Yes.
Right. Well, that's fine. That's just, I just suddenly got a bit worried that I'd missed a witness. And so just to finish that topic, how would you have learnt of this viewpoint within?
My policy team would have advised me. So when we were talking about, this is again, my unease was growing about what was happening within Greater Glasgow and Clyde. And it was the ruling out rather than ruling in. The assumption people were becoming polarised, I think, by this time, of it was definitely the water, it was definitely the environment, or it definitely wasn't, rather than actually being able to hold a number of concepts and look to rule out. So look for specimens, look at the clinical condition of the patient to see whether it was translocation rather than contracting from the environment.
If it's a problem to be too definite in one direction, that it's colonisation, surely it's actually a problem to be definite in the other direction.
Yes.
Yeah. But when do you have to make your mind up? Because we know, for example, that Miss Rankin at the end of the month has picked as her hypothesis 2 water-related sources. So is there anything wrong with her doing that at the end of May?
None whatsoever.
And so what's the distinction? I just misunderstand you. What's the distinction between Dr. A taking the view that, like Dr. Inkster does in the instant tea management report, that it's the water, Ms. Rankin taking the view at the end of May that it's the water, and whoever this other person is taking the view that it's translocation? What's in a sense wrong with any of those 3 positions?
So I think you have to come to ideally, if you can have a direct causal relationship with finding the organism in the environment, whole genome sequencing, and finding that same organism in the patient. That's the most straightforward piece, how you can say it was definitely from the environment and this is where it was from. If the best judgment is it was from the water, given the variety of assessments that expert infection prevention control colleagues carry out, then the important thing would be openness and transparency, so duty of candour in terms of advising the patient or their family. It would be about putting control measures in place and making sure other patients were protected from that source of infection. And as long as that was done, then that was the important matter. And other aspects of professional disagreement could be taken. What was important was the control measures were put in place. If there was professional disagreement about whether or not it was the water, then that could be an ongoing factor as things progressed.
So you're thinking this will come back as an issue in 2019, but you appear to be saying that if there's a professional disagreement, the important thing is the need to act. But in the case of, well, what's about to happen in September, acting is complex, difficult, and expensive because it's to decant the unit.
Yes.
So doesn't there get in these processes a point when you actually have to make a decision and pick a hypothesis, and then holding out for the other one is actually unhelpful? Or is that just too much of an exaggerated position?
I think that then means you've ruled something out that was a possibility. And if you don't keep that bubbling away as a possibility, then you're perhaps narrowed down too quickly. Now, because we now know it was the water, it's perhaps easy to take that view. But if there are other possibilities that remain possibilities, I think that's important not to ignore.
Why do you say we now know it was the water? If I understand it's NHS Greater Glasgow Division, it's not the water.
Well, the water was contaminated, is my understanding.
I think it's NHS Greater Glasgow Division that the water wasn't contaminated.
They may well think that, but the advice that I've received is that there was contamination within the water.
I think that's probably, my lord, an appropriate point to stop for coffee. I'll go and find these Corporate Governance Committee minutes that I mentioned. And if they need to be looked at, I'll make sure you get a copy.
Thank you.
We'll take our coffee break now, Ms. McQueen, and if I could ask you to be back for 10 to 12.
Yes, thank you.
Please stand.
Mr. Mangan.
Thanks, Lord. Mr. McQueen, one of the features of this is that the colleagues in the room will get to suggest questions I should ask. So I've got a couple of things to go back to. The first one, you mentioned the use of whole genome sequencing to confirm connections between environment and infections. Do you have a view on whether in 2018 there was any sort of requirement in terms of professional practice or what should have been done at the time to collect such samples in a systemic way for whole genome sequencing in 2018?
So I don't have a view, and if I did have a view, it would have been formulated from professional advice from infection prevention and control experts. So I don't think it was the expectation that would be happening. I'm just using that as an illustrative example of where you can be definite about the source of infection, but just because you haven't identified an organism doesn't mean that's the same as the patient has been infected by, doesn't mean to say it wasn't contracted from the environment.
Thinking back to 2018, do you remember any discussion about the possibility of using whole genome sequencing?
I don't. There may well have been possibility, but I don't remember.
Next thing is, I think I might have confused you about the framework. So what I'd like to do is to go back to your statement and to go to paragraph 24 on page 80. Now, this is where you discuss the National Support Framework, previously known as the CNO algorithm, and that's in the 2017 version. It's in Bundle 27, Volume 4, Document 15 at page 161. Twenty-seven, 4, 161, please. So is this the framework that you invoked in that email to Dr. Armstrong in 2018?
Yes.
And if we go back to your statement on, well, in fact, we stay where we are, look at the first paragraph there. Last line in the first paragraph, this framework supersedes the CNO algorithm 2015. Would the CNO algorithm 2015 have been what you would have invoked in the Serratia cases in 15?
Yes.
Right. Is that not, in fact, different from the stage 2 and stage 4 framework activated by the CNO and others in 2019 into 20?
Yes.
The result from the Oversight Board?
Yes.
Brilliant, thank you. Now, what I want to do now is, you mentioned the need to report. If we go back to the email to Dr. Armstrong from the 20th of March 18, that's Bundle 52, Volume 8, Document 2, page 39. Now, you mentioned, I think if I understood correctly, that you felt that this should be reported to the Clinical Care and Governance Committee.
Yes.
Yeah. So I've dug out the minutes of the next meeting, which is the 12th of June 2018, and that is Bundle 38, Document 7 at page 44. We gave you a copy over the copy break.
So I do have a copy. Sorry, could I have so I have a copy of the minute here.
Yes.
May I have
the email back?
The email back.
Certainly,
please?
yes. 52, Volume 8, page 39. Yes. Sometimes the computer gets a bit sad.
Thank you.
Right, so we go to the minute, which is, as I said, 38, Document 7, page 44. This is a meeting of the Clinical Care and Governance Committee, chaired by Ms. Brimlow, and in attendance, amongst others, is Dr. Armstrong. And I think the item that we might be looking at is item 22 on page 47. Now, presumably you won't have seen this before.
No.
No. The minute presents this as a presentation by Dr. Inkster. Do you find in the minute a reference to the invocation of the framework?
No.
I mean, maybe it's reported elsewhere.
It may be that it was in Dr. Ringster's presentation, but it just hadn't been noted in the minute.
How unusual is it for a health board to be subject, if that's the right word, the subject of an invocation of that CNO framework?
I would think it's quite unusual, and I would have expected the committee to have been advised of that. And had I been the committee chair, I would have wanted that recorded.
I mean, if we think back to that sort of period, so 2018 and earlier, approximately how many times in a year might you in your office invoke?
I'm sorry, Mr. McIntosh, I don't know, but it would have been, I would need to go and count, but it would have been, I would have thought less than 8. So not.
And that's across all the health boards
yes.
in Scotland. And how many were there then? 13 is ringing a brain in my brain, but I'm wrong.
I was going to say 15, including the island boards. I don't know, but yes.
But it's not a weekly occurrence.
Absolutely not.
That's right. Now, I think probably I'll pick this up now. We talked briefly about the need or potential need, or was there a need for some form of enhanced audit inspection functionality? And it's been put to me that what we probably would, how do you feel about this? The idea of creating something similar to the Care Quality Commission that exists in England, a statutory body that can inspect on its own account rather than requiring a board to self-inspect or audit. Do you have a view on whether that would be a good idea?
Do you mean have the self-inspection or a regulator?
A regulator like the Care Quality Commission south of the border.
So just because there is a regulator south of the border doesn't mean to say they don't continue to have problems, because there are problems if you watch what's happening in the media with their maternity services, and they've had a regulator now for a number of years. I do think it's worthy of consideration. And as I said earlier, there are layers of bodies and agencies, either to be supportive or to inspect or to look at improvement. And there's many others that perhaps people aren't aware of in terms of looking at the radiology standards, in terms of IRMA regulations have to be progressed. There's laboratory regulations that have to be processed. So there's many bureaucracies that are put in place, rightly so, for safety. So I don't think I would be arguing automatically for a regulator, but I do think consideration of it in the overall round of things would be helpful, because I think in terms of looking at the range of outcomes you would be expecting on perhaps a more regular basis than we're seeing just now from Healthcare Improvement Scotland. And I also think the autonomy to choose where to go.
So what do you mean by the autonomy?
So rather than be directed by the Cabinet Secretary or follow a programme, to actually pick up an intelligence and then go in and inspect on an unannounced basis, it would be helpful.
So it's a combination of ability to be autonomous from the political leadership and the ability to actually do the inspections yourself.
Yes, although I do think we live in a democracy, a representative democracy. If the Cabinet Secretary for Health is concerned about an area of the health system, I do think they should be able to ask the regulator or the inspectorate to go in and inspect. So although you're saying independent from politics, I do think there's quite a relationship there that you wouldn't want the Cabinet Secretary for Health not to be able to direct agencies. And
am I right in thinking from what you just said that there's also a need to remember there are lots of other relatively small regulators and inspectorates out there, and perhaps think about them at the same time? So there might be some that would get merged into such a thing. We need to think about it.
Yes, or think about the burden of oversight of organisations in terms of making sure that what you're expecting to get at the end of it is actually what happens. So it would need careful consideration.
Thank you. I want to go back to your statement to paragraph 41, which is on page 85. I'd asked you about the sentence in the middle of the paragraph, that understanding was not, however, universally accepted. And then I think we've already discussed this. Nonetheless, because water was one of the hypotheses, the source of infection, control measures were put in place by GGC. Now, it's the next sentence I wanted to try and understand. It is important to note that the fact that the water was considered to be a source of infection does not necessarily mean the water system as constructed and commissioned was defective. Now, what do you mean by that?
So you can have a perfectly formed water system that meets all the regulations. The authorising engineer for water is content. It has excellent and outstanding maintenance, and to all intents and purposes, the water system is safe and effective. But something can happen. There could be splashback from drains. There could be biofilm forming. There could be stasis. There could be lack of proper flushing that then causes the contamination. So just because there was water contamination in the Queen Elizabeth doesn't necessarily mean that there was wholesale contamination from construction.
Now, you've obviously expressed that view. We obviously can see the two 2018 reports from HPS. We can see the draft later report from HFS. We can see Intertech's report. We have Dr. Lee's opinion. We have Dr. Mackin's opinion. We have the Water Technical Group opinion. And we have our inquiry experts and other experts. I want to just check, at this point, during 2018, is there another piece of work that's been instructed by Scottish Government?
Not that I know of.
Not. So this is your view taken from all the material and your general understanding?
With hindsight, but it was not my view in 2018.
Right. What was your view in 2018?
That there had been water contamination that happens, because you have that in right across the country. There will be areas where there's water contamination, but control measures are put in place, whether it's flushing or other treatment of the water, and that then rids the system of contamination.
Now, I appreciate what you've said is not a statement of fact, because have you made a study of, for example, the actual authorising engineer's reports? No. Or Mr. Poplar's reports?
No.
No. So this is just an observation of what might be the case?
Yes.
Right. And then on paragraph 42 over the page, you mentioned the 2018 report from HPS. But before you do that, I want to go back to the timeline. So that's bundle 52, volume 1, page 619. And at the foot of that page, on the right-hand side, you mentioned September 28, a series of weekly teleconferences with GGC and HPS began in September 18 until January 19, chaired by Scottish Government, and they concern the handling of the incidents. Now, I'm not convinced I've seen these the minutes of these. I may have misunderstood, but who was participating in these?
So I don't have the detail
Right.
of it. It would have been, I would have been advised that they were happening, but
this might be towards the physical building systems end of the discussion rather than infection prevention control.
So it may have been.
But it's not, if I understand it correctly, the HR unit has infection control nurses in ARHI to some extent reporting into it. It's not, as far as you recollect, an IPC teleconference system. It's something else.
Yes.
Right. Then you then report an escalation. Now, if we if we go over the page, the timeline from the Scottish Government reports Deputy Chief Nursing Officer escalates the situation in GDC to DG Health. Now, that's not you, that's your deputy.
Yes.
Do you know why that escalation took place?
I think she was concerned that the DG needed to know, because a lot of routine policy work is, whilst it's not routine to the individual patient if they're infected, the routine of having information reported, incidents reported, and is taken in one stride. But I think the DCNO felt that this was material and the Director General needed to be aware of it.
And we have on the left-hand column a 23rd September date about case numbers and the wards being decanted. Now, we know the decant decision happens on the Monday 17th, or it might now be the 18th, I can't quite remember, September. And are we to take it, would it be not until the 23rd that the Scottish Government learnt about that?
I think if that's in the timeline, then in terms of maybe formal notice, but again, I couldn't
You may
say
have heard about it through RI.
without looking at documents.
And is it entirely possible that on the 25th of September, it's simply that you're on annual leave?
I was on annual leave.
Right. Okay. Now, at the risk of having a conversation about frameworks I might get wrong, should we read anything into the word escalate here? Or is it simply just, I'm going to tell you because you should know? If there's nothing formal.
You're reading too much into it.
Right, okay. Now, the redacted section below makes reference to the ACOM report, which the inquiry hasn't recovered because we understand it was produced by DGC in anticipation of legal action. But you knew about the ACOM report at this stage? Yes. So I'm going to use this as a hook to work out what you knew at the time. So we're looking at November 2018. What would you have understood to have been the what we've called potential deficient features of the building at this point? So this is November 18.
So I don't remember what I knew when. I don't think I was advised of the ACOM report being commissioned, but I certainly would have been told once it was in progress and when there was information and knowledge about some of the faults that had been found.
But what was your knowledge, as far as you can recollect, towards the end of 18? And I'm choosing that as before the Cryptococcus case is. We've obviously got the DMA Canyon report emerges, both of them. We've got the water incident, and we've got both reports from HPS. So I'm assuming you have a knowledge about water as an issue.
Yes.
And you know about the horn taps.
Yes.
And you know about what you call contamination and what others call contamination of the water.
Yes.
What's your state of knowledge about issues around the hospital's ventilation system at this point before we get to Cryptococcus?
So I don't know. It would depend when the ACOM report was made available to.
But it's after this date. So that's the point. There's a point here when ACOM's about to turn up. And so I'm thinking before you get any knowledge you might get, do you know of issues around ventilation in 2A, general wards, in isolation rooms, 4B at this point?
I can't remember the sequencing of it in terms of when I knew and when I didn't know of the way that the system's ventilation, the way the hospital's ventilation system had been designed and built.
I'll try and explore it a bit more because it may be possible to extract something. If I'd seen you end of October 18, and I asked you and you'd been willing to give me an answer, and you'd been willing to give me an answer, what would you have said? This is a water-based problem, potentially? Or would you have seen that ventilation had anything to do with it?
So I would have taken advice, but I probably would have seen it as a water-based problem rather than ventilation because the organisms were cultivated in water. rather than, well,
Thank you. Now, if we go back to your statement, paragraph 43, page 86, you say you believe you were made aware of the DMA Canyon reports in autumn of 2018. Now, we have evidence from quite a few sources that it's the end of June, start of July, when Professor Steele from HFS visits Ms. Grant with the reports, which he's received, I think, from Mr. Storer or his team, who have received them from a GGC data dump. And as a consequence of which, there's then a presentation to the board in July. Do you think that would have happened before you learnt about them? Or would you have learnt about them before GGC learnt about them?
No, I did not learn, and I would be surprised if I learned about the DMA Canyon reports before GGC. I believe I was advised that they existed, but by that time, both Health Facilities Scotland and GGC knew about it and were working on a solution.
You mention the summary of incidents by HPS, Bundle 7, Document 2, page 32, in paragraph 42. And I think it's page 32, yes. And it's December 18. Now, I probably should have asked this question to Ms. Rankin last year or this year, and I didn't. But it occurs to me, reading your statement, that this is a question to ask. Can you help us about why this report doesn't mention DMA Canyon?
So my understanding is Health Protection Scotland, in part of their investigation, asked Health Facilities Scotland to assist them.
Yes.
And it was by providing that assistance that Health Facilities Scotland came across. When I say came across, I don't know whether...
No, it's not quite clear, but it seems to have been found, yes.
They found the DMA Canyon report. And that was being dealt with through Health Facilities Scotland. So it was being dealt with almost by a separate, not in a secret way, but being dealt with in a separate stream. So my understanding, and then I think the Health Facilities Scotland created a report, I can't remember if it was published or not, which would have been early in January or February the following year.
Well, that's the thing, because there is a draft, but it's draft, it's not final. And there's two reasons that make me ask this question. One is this point that there's no HFS report effectively to you and your colleagues in Director General in the DG about we found the DMA Canyon reports, this is what they might mean. That doesn't seem to exist in 18. And we also have the slight oddity that an epidemiology situational assessment that started by Ms. Rankin in the summer of 18 does not get shown to GGC in draft till January and isn't published till later in 19. And I'm wondering whether there's any observations you make about the resource level that was available to HFS and HPS to address not so much the infection control things, because there's nurse consultants in every meeting, but the rest of it, the epidemiology, the system, water systems. Were these organizations set up to deal with an incident of this scale?
So I think it probably they hadn't been anticipated there would be an incident of this scale or complexity when they were set up. And it would have been, I do remember that some of I think it was actually Annette Rankin underwent additional training in terms of water so that she had the expertise to carry out some of her duties. It would have been for both organisations to request further help and further resources, but it may well be that the level of technical expertise was being stretched, but I couldn't say.
I just wonder whether, because we know, for example, that within GGC, Dr. Inkster felt stretched. And at one point, there's a suggestion there might be further sessions for ICD doctors, and it doesn't quite come to pass, but that is certainly on the agenda. And therefore I wondered whether, from your perspective as CNO, the idea of do we on the, I know NSS is a separate agency, but on the government side of this incident have enough resource? Did that topic come up?
I don't remember it coming up, but it's something that I think with hindsight we should have reflected on and asked the NSS, did they have sufficient resource to be able to meet the needs of Greater Glasgow and Clyde?
What I want to do now is to move forward into the new year. And we picked up in paragraph 44 of your statement at page 86, which is the Cryptococcus cases emerging. Now, you discuss the death of a patient towards the end of 18 at the bottom of that page, and over the page, another patient who ultimately dies, and you receive an update from HPS towards the end of January. Now, there is a letter by DG Health on the 25th of January 2019, which is actually in an Edinburgh hearing bundle for the hearing on the 26th of February 2024, bundle 4, document 3, page 8. No. So it's the Edinburgh hearing, Edinburgh 3 hearings, hearing commencing 26th of February 2024, bundle 4, document 3, page 8. Thank you. Yes. Now, I appreciate that if we just step over the page, it's from, not back again, sorry. This letter, page 8, is from the Director General himself, not from you. But are you aware of the reasons this letter was sent?
Yes.
So can you help us understand what was driving the decision to issue it?
I think it's about how the whole NHS system learns, and if there were issues discovered in the Queen Elizabeth, rather than as expecting by osmosis that information and knowledge to go around Scotland, the Director General decided that there were certain things, again, regardless of causality, that needed to be looked at in terms of, in this case, it was pigeons, but, well, I don't need to repeat what it says. So it was to advise chief executives of boards that they needed to take action to review their current situation within their boards.
One of the things that's not or might not be present is in the fourth bullet point. All critical ventilation systems should be inspected and maintained in line with SHTM 0301, ventilation of healthcare premises. Can you help us about why it doesn't say all critical ventilation should be inspected to see if they are in compliance with SHTM 0301, ventilation of healthcare premises? There is a difference there, which I understand, but I wonder if you can help us why it doesn't go that far.
So I think there's probably a number of factors. If we have a hospital estate across Scotland of varying ages, and therefore the ventilation in the estate is a variety of standards of ventilation. And so therefore that is one thing in terms of what the standard of ventilation is across Scotland. There will be different air change rates in different rooms depending on when the building was built. My understanding and what I recall from this aspect was it was actually about the maintenance and essentially cleanliness. So in terms of making sure that there couldn't be contamination of ducts. So air handling units need careful tending. They need to be maintained. They need to be cleaned. The ducts need to be in a good position so that there's adequate airflow, otherwise mould and other organisms can grow. So I think this actually was not, I don't think there was a conscious level of the ventilation rates and air changes that came about through.
This is more a maintenance
ACOM.
issue.
This is about maintenance,
right.
Yes.
I want to pick up the your awareness of what's going on in the IMTs around Ward 6A in 2019. And I wonder, you had invoked your framework in March. That point around the time of the Cryptococcus cases, what was your sort of state of, I'm not sure concern is the right word, but your level of interest / concern about the way IPC was being managed in the Queen Elizabeth over that winter?
So incident by incident would be looked at, and I hadn't been alerted to issues of IMT management with regard to the Cryptococcus patient cases. I think there were other areas that were beginning to come through. I think from ACOM that there had been mould and other aspects within the building. But in terms, as far as I recall, of the IMT for Cryptococcus, I don't.
You don't remember that coming real to your attention?
No.
I mean, to be fair to say, there is a professional judgment in our high about whether to tell you things.
Had our high been concerned, they would have alerted us.
Yes. And their decision to withdraw from to not accept the conclusions of the Cryptococcus subgroup is many months away at this point. I want to look at an email that was sent from Miss Imrie at our high to Mr. Birch. Would Mr. Birch have been part of your team in 2019?
He was a policy lead, yes.
Yes. And this is on the 16th of August, 2019. So it's Bundle 27, Volume 5, Document 7. 27, Volume 5, Document 7, page 24. So we've had some evidence about this in the inquiry, and it's fair to say that Dr. Peters has identified herself as the whistleblower, and we have the correspondence. So there's no point, no, we don't have to maintain that at the moment. But this appears to be, well, from the covering sheet, we know it's the 16th of August 19. Well, we don't know the date of this email. We know that the contact by Dr. Peters on the 16th of August 19, after an IMT on the 14th of August. And was this issue brought to your attention around about the time in August of 19?
So it may have been. I can't recall, because as we moved into the autumn of 2019, there was increasing, I hesitate to say intelligence, but there was increasing messaging back and forward from Glasgow and Health Protection Scotland about the way that IMTs were being conducted. And I can't quite remember when this would have fitted in. I would be surprised if Jason Leach hadn't advised me.
Birch.
Jason Birch hadn't advised me.
The reason I wanted to go on with the chronology and see if that helps you. So we obviously have had evidence about an internal meeting on the 20th of August, chaired by the medical director, which decided to remove Dr. Inkster as chair of the IMT. Was GG still subject to the invocation of the framework at this point, or had that dropped off?
It tended to be for incidents at a time, so
it would have ended.
So it would have ended.
Right. And the national framework, had that been engaged at this point?
No.
No. And so given that GGC medical director and a number of senior managers had met and decided to remove Dr. Inkster, and then there's the meeting of the IMT on the 23rd, which appears to have been relatively bad-tempered, and in and amongst that, there's a high discussion of whether it was all handled properly, to cut it short. Did you learn about those events in August?
No, I didn't. Day-to-day bad-tempered meetings, issues with relationships, that is for the board to manage and deal with in an appropriate way. I am likely to have been told, because I think, and again, I'm not quite sure when it happened, but Health Protection Scotland started to double up because they felt they needed moral support.
Would you have known about that?
I don't know when I knew about it, but I certainly was told about that in terms of they were concerned about the tone of IMTs.
And then Dr. Inkster resigns as lead ICD at the start of September 19. Now, you met her on the 4th of September. Had she resigned by that point?
I don't think so. She may have told me she resigned. I can't remember.
Did GDC tell you she resigned?
No. And on the one hand, whether or not there's an infection control doctor resigns from their role because they remain a microbiologist, it's an additional responsibility. That would happen, when I say quite frequently. Doctors change their roles, they change their specialties. That in itself isn't unusual. I think my understanding about why Dr. Inkster resigned is unusual.
But you didn't know that at this point, did you?
I can't remember. Dr. Inkster may have told me at the meeting, but I really don't remember.
If we look at her resignation letter, which is bundle 14, volume 2, document 151, page 579, we see in the 4th paragraph quite a precise summary of her position. Now, you've had an opportunity to read this in your document list. I'm not going to go through it now, but how much of this would you have known in August, September of 19?
I don't think I knew much of it at all, but again, because clearly this is signalling a big problem. So I'm not suggesting it's not, but workload of clinicians is a reason for them demitting office. But I think in this case, it's clearly a signal from Dr. Inkster that there was insufficient resourcing and the culture.
Well, I think it's more than resourcing. I think it's undermining lack of respect as well. The reason I ask you this is because in a few months' time, you're going to, if I understand correctly, authorise the reopening of Ward 6A to new admissions. And when you made that decision, did you know, in a sense, how it was that Dr. Inkster, even from both sides, because there's Dr. Armstrong has a different take on this, did you know either sides of the story at that point in I think it's November when you authorised that?
So I did know there was conflict in the team, and I did know there was more than two sides in all of this in terms of difficult relationships, lack of transparency. And I got that from a variety of sources. So when 6A opened, I was content that it opened on the basis of Health Protection Scotland.
Because Dr. Inkster tells us in her statement, which is witness bundle of the 30th September for Glasgow 3, I won't put it to you on the screen, but she tells us in paragraph 556 that she told you about a number of issues, including concerns she had about some historical cases in 2017. Do you recollect that?
Yes.
Yes. And that she also told you about the way she'd been treated, because that's why she comes to say, which you deal with in your written statement, that you said that someone was being mean to you. So the reason that she thinks you said that, and I accept you don't remember saying it, is that she tells you the way people were behaving towards her.
Yes.
So what I'm suggesting is that by the time you met her on the 4th of September, you had at least heard from her, if not through RHI, and you maybe had heard through them as well, if not from Mr. Birch, because of that email from Miss Imrie, that there was at least 2 microbiologists who were expressing concern about undermining culture and so on and so forth. Would that be a fair sort of summary?
Yes.
Did you attempt to find out more by perhaps asking RHI for more of their take on it? Because presumably they'll be more on the ground.
So I would have asked my own policy team rather than necessarily RHI, and they would have asked RHI. So the intelligence I was gathering was one of conflict in the infection prevention and control space. I don't remember the sequencing of it, but I absolutely knew that there was a retired microbiologist and 2 microbiologists who were actively working in GG&C who were concerned about the culture, lack of transparency, and the way that IPC was running.
Because I suppose I have to put to you that in a different context, different way, not same context, different way, you've previously, in 2015, had some concern about the way IPC is being run, and I think at a very high level in the Queen Elizabeth. And again, you were careful to say it was a concern rather than a reason for thinking it. You were concerned about the way they were handling the water incident to some degree in the previous year. And at this point, there's been a lot of media interest. You'd accept that?
Yes.
And so, how would you react to the suggestion that in September of 19, you actually have pretty much available to you the same evidence that we have available to us now? What is it now? Nearly 6 years later.
So I think as the weeks went on, so I would ask my team to find out more about what was actually happening within Glasgow. And as the weeks led up to the formal escalation of using the governance framework rather than the CNO
format algorithm.
Yeah. Then that was influencing and shaping my thinking. So my meetings with Doctors Peters and Ingsters and the retired microbiologist helped shape my thinking about what needed to happen, because it was clear that intervention was needed. But talking to the chief executive and the medical director, they knew and understood that there were problems and they were trying to manage it. Because in September, I hadn't sent 2 of my team to go and observe an IMT. We hadn't spoken to the parents in wards 2A. And we hadn't had a wider view. So that was perhaps a catalyst to further activities that were happening.
I mean, you now know that Dr. Inkster and Dr. Peters had raised broadly similar issues in 15.
Yes.
I mean, you didn't know that then?
No.
You weren't told by the medical director and chief executive why Dr. Inkster had resigned. You heard it from Dr. Inkster?
Yes.
To some extent?
Yes.
Is that not a bit of a red flag that you meet the chief executive and medical director of a health board who's under this high level of scrutiny? You know, I mean, you can't remember the full details of what Dr. Inkster told you, but you know in broad terms she has concern about infection, she has concern about duty of candour, and she has concern about the way people are being treated, including herself. And that when you meet the medical director and the tutor, you're telling us they didn't tell you why she'd resigned.
So I think their perspective was their perspective, and there were other issues that were surrounding Drs. Ingsters and Peters that they needed to take into consideration.
What other issues?
Well, I think there were other members of the team who were unhappy with Dr. Ingsters and Dr. Peters' response. So it wasn't as a straightforward binary they're right, they're wrong.
No, I appreciate that.
It was much more complex, and therefore it maybe was a red flag. But I think already my thinking had started that this needed more significant intervention than was already been there.
Just to be clear, my point is not that there wasn't perhaps multiple perspectives on this, because that may well be the case. And we've heard of all those perspectives and evidence, and we have to ultimately decide what to do with that information. But it's the fact they didn't tell you. If your position is that you weren't told why Dr. Ings resigned, even if it turns out that she's wrong to have all those views, it's the fact they're not upfront with you to tell you that this is what's going on in their IMT. Isn't that a problem?
So I don't remember when, although I'm saying I don't think they told me, I don't remember being officially told that she had resigned by the chief executive and medical director. There are so many things that happened over that period of time, I can't. But if they didn't tell me, then given the circumstances, it perhaps was unusual, but equally a doctor resigning from a role when there are thousands of doctors involved in Greater Glasgow and Clyde may not have been at the top of their mind.
I mean, it's been put, I think it was a question I was asked to put to Professor Stephen when he gave evidence last year, that there's a view, and it was suggested that he might hold that view, and he gave his response. But the view that was put to him was that, and it might have been put to Mr. Professor Wilcox as well, that there's a reluctance to engage with whistleblowers because there's a sort of slight assumption that they might be somehow aggrieved and therefore not entirely unbiased. Was that your response?
Did I have that view?
Yes.
Absolutely not.
If we look at, I want to step on to the meeting that we talked about earlier on 25th September. So that's bundle 52, volume 1.
Mr. McIntosh, I do
Yeah.
apologise. May I come back to the whistleblower piece?
Yes, of course.
I engaged with the 3 microbiologists, but in particular Dr. Peters and Dr. Zingsters. I invited them to meet with me. I asked my specialist infection control nurse to link with them and liaise with them. I had serious concerns about their welfare. I absolutely took what they were saying at face value, and I believed what they were saying. And I recognised and understood their distress. So at no time was I thinking that they were not to be listened to.
Understand. I'm sure we will return to this, but what I want to do now is to look at the meeting on 25th September. So that's bundle 52, volume 1, document 37, which is the timetable again, page 624. So do you see in the right-hand column, there's a series of events described. 9th September, HPS notified the Scottish Government, highlight red. 17th September, we are announced as a public inquiry. And then on 25th September, you meet with GGC, HFA, HPS, discuss the management ongoing incident in relation to increases in gram-negative bloodstream infections in 6A. And what I want to understand is, can you help me who might have been present from GGC at this meeting?
I think Dr. Armstrong was there.
Yes.
I think there was a senior infection control nurse. I can't remember of microbiologists.
And might this have been around the time of Professor Leonard and Professor Jones's SBAR suggesting the ward was safe to reopen? And I think the RHI nurses attending in pairs took a different view. Does that connect to this, or is it a different?
So the reason I called that meeting was because there was an increasing intolerance of differing views, and there was differing views. And what I wanted to do was understand what was happening within Greater Glasgow and Clyde. And I do remember them giving a presentation about their infection rates and the ongoing dialogue that we had, because there was senior clinicians from Health Protection Scotland, because there seemed to be disagreement across the organisations and I had wanted to understand, I wanted to have everyone in the room so we could talk about the best way forwards to make sure that we could get the hospital as safe as it needed to be. So I can't remember when the SBARs were coming out, but I knew there was certainly conflict between.
So if we see this as part of the process that ultimately leads to the reopening of the ward, as an assurance process, that's the way to see that.
Yes, but it wasn't always routinely planned to be that.
No, but that's where it ended up. Right.
Yes.
Okay. Just while we're talking about the way you've expressed that, you talked about increasing intolerance to different views, and you talked about the complexities, the technicalities of it. And we had an earlier conversation around about 11 o'clock around different views in IMTs in the context of relatively calmer periods in 2018. And you mentioned Sir Robert Francis's report and the importance of being able to speak up and be heard. Have you got any thoughts about how that task of enabling people to speak up and be heard and the organisation to listen is made harder or more difficult, and of course you might disagree with me, in an area where it's quite technically complicated? Like, is there an infection link? And where some people claim to have expertise, as you do, and some people have just acquired knowledge over their years, perhaps like a state officer. How do you resolve that when it is both a question of culture and a question of what's right?
So there is something about, and if you take infection control, clearly estates and facilities have a huge part to play. Consultant microbiologists, nurses, general managers, the treating clinician. So they all bring a different perspective. I think in the seeking to understand and the being respectful of other colleagues, then the dissent is good, because by working through that dissent, you actually find the best possible solution. So I don't think we should be afraid of having different perspectives. I don't agree it becomes much more complex it becomes more complex, but I don't think it should matter, because most boards around the country actually can manage this perfectly well. So I think the culture of speaking out, of being respected, needs to be created, and it's a leadership issue so that people can feel safe and secure in raising issues that other people either are not wanting to raise or are testing something out that might be unpopular. And there needs to be the space and time, and maybe we'll come to this later, about the organisation of IMTs, so that people feel they've got papers in advance to read, they can reflect, and they can have open, active discussion about it. And that's what I would expect to happen at an IMT or higher up the organisation in terms of the organisational boundaries.
Thank you. What I want to do is just pick up, I think we've actually already answered this, but we're obviously conscious from reading SBARs that HPS, HFS were providing support around 4B and 2A in 4B's case from 2017, and we have a January 2018 SBAR for 2A. We know that in May, June 16, senior members of the board, that includes the medical director, the director of estates, who was the project director, and indeed Dr. Inkster, and quite possibly the chief operating officer, and I think the chief executive, all knew that the general wards of the hospital had a ventilation air change rate of 3 or less rather than 6 air changes now. Now, they all have a different take on what should be done about it at the time. So that's not the issue. The question is, when did you learn about all 1,300 wards, rooms in the hospital operating at half the recommended air change rate?
I suspect it would have been in the autumn of 2018 when the rest of I hesitate to say building deficiencies, but when the rest of, either through the ACOM report or when HFS found the water issues, I was maybe also told that there were other issues within that.
Right. Now, we've also had a lot of evidence about the three microbiologists who you've mentioned, Dr. Aiden, well, not three, actually not three, a different three microbiologists, raising an S-bar on the 3rd of March 2017. And that results in a 27-point action plan, which goes to Corporate Clinical Care and Governance Committee on the 5th of December 2017. So it's bundle 20, document 48, about page 793. Go back one page to 792. So this is the paper. And then we go to 793 is the key lists of the themes raised by these consultants. And then 794 is a 27-point action plan. Now, as far as you can recollect, when was the Scottish Government first told about the existence of the 27-point action plan and how it had come about?
So having an action plan in response to issues wouldn't necessarily be something to let the Scottish Government know about. I think I knew about this through doctors, through the microbiologists speaking to me, saying that they raised issues and they hadn't been responded to. And when I'd raised that with Dr. Armstrong or Mrs. Grant, they said, well, it had been because the S-bar had been created and an action plan had been created. So there was a difference of opinion about whether or not the concerns had been responded to or not. And I think that was probably in 2018.
What I want to do is to think back to something you said last year on the 7th of March 2024. It's in column 199 of your transcript of your evidence. I think it'd probably be only fair to put it on the screen. You're being discussed, we're told, you asked a question by my colleague about a line in the table, the guidance to the back at SHTM 0301 that deals with, I think, neutropenic areas or something like that. And you go, yes, and it's put to you what it recommended. And then you're discussing what's going on in the Edinburgh Hospital at the bottom of the column and the role of the Oversight Board in Edinburgh. It seems only appropriate to ask you to look at that table and ask you a question about it in the Glasgow context. So it's bundle 19, document 40, page 940, which is SHTM 0301 2009 draft. No, it's not. I have to get the right one. Can you just go to page 1108, just in case I've corrected myself? No, that's the wrong one. Sorry. Sorry, bundle 16, document 5, to page 483. So this is the table from the 2009 version. If we could zoom into the top half of the page, please. Now, that's a bit close. Thank you. And you see there's a row there down, 9 rows down, neutropenic ward, ventilation, and it describes the 10 air changes, positive pressure 10, H12, S-ply filter, and so on. Now, am I right in thinking that you've actually looked at this version, at least in the later version of this report?
Yes.
Yes. When all these events are going on in 19 and D20, did you look at this version of SHTM 0301?
About the air changes?
No, it's about the definition of a neutropenic patient ward. Now, I realize you're not a hematologist, but what do you understand to be a neutropenic patient ward, and why do you understand it to be whatever you understand it to be?
So people who have neutropenia can be needing a variety of care, so would be expected to be nursed or cared for in a variety of areas. So hemato-oncology patients may be neutropenic because it's not necessarily a long-standing issue. So you may have hemato-oncology patients. Transplant patients may be neutropenic. People with autoimmune diseases may be neutropenic. So I'm not as familiar with a neutropenic ward as such as what environment would you care for a patient who is neutropenic?
Well, that prompts me to say this. If we put ourselves into the shoes of, in this case, Mr. Pardee, who designed the ventilation system for Ward 2A and 4B and so on and so forth. Someone, an M&E engineer, is looking at this table, and it says neutropenic ward, and nowhere else in the document does it say what that means. And there's no row for bone marrow treatment ward. No. There's just neutropenic ward. And I suppose one version of events could be a neutropenic ward is a strange, unusual specialist space. It's quite rare. And the other version of events could be a neutropenic ward is any ward on which you treat patients who are neutropenic, which might include a cancer assessment unit. It might include, well, in the Glasgow context, Ward 4C. And so appreciating that it's not your technical field, but you were the chief nursing officer and then the chair of the oversight board, I wondered if you'd ever got a handle in your own mind about what it means. Is it quite a broad brush thing? Were there lots of them? Such as the place I mentioned?
I'm not a building services engineer, no. You're absolutely right. But I do understand the importance of a safe and effective environment for patients. And people with neutropenia can be a transient state. So if you're a hemato-oncology patient, you may be neutropenic and then you're treated and then you're no longer neutropenic. So it's not permanent in terms of labelling individual people. So I think any design engineer who's designing healthcare systems should be well aware of the fact that there needs to be facilities for patients with neutropenia. And that may not be all 1,200 beds, it may not be 2 beds, but the dialogue that would go on when commissioning a building should include where do you need that level of care. And if you don't know what a neutropenic patient, if you're a building services engineer and you don't know what a neutropenic patient ward is, then you would ask.
So it's a combination of the engineer should ask and probably the clinical output specification should say, this is a neutropenic ward.
Yes, or these are the areas where, whether it's, in this case, let's keep it to the positive pressure, these are the areas where we need that within a hospital. And it may be pockets across the hospital, or it may be everyone grouped together.
Can I just explore this a little? Just in my attempts to understand what the table is attempting to say, it does seem to me, and I want to be corrected if I'm wrong about this, that a natural meaning of a neutropenic patient ward is the whole of the space in which a patient who is neutropenic, possibly transiently, may be treated. Now, there's 2 elements in that. In other words, what I have in mind is the whole of the clinical space, and the other is where a patient may be treated, bearing in mind the possibility that at a particular point of time, no patients in the ward may be neutropenic, but it being probable that at some time, some of the patients will be neutropenic. Now that's how I come to the text. From your perspective, is that a right way to come to the text or not?
So I think so, my lord, but you wouldn't necessarily have all, although I think Tweed ended up being that in terms of all at the 10 air changes, if you would have a sufficiency of rooms for neutropenic patients, that may be satisfactory. So yes, if you can have the ensuite bathroom and shower room and their bedroom, that may be sufficient for them. I think you're maybe alluding to the patient pathway in terms of if that patient has to leave that room, where do they go? So that would be an unbalanced decision, because you're not going to have that across the whole hospital. And you would need to make a decision about how you're treating that patient. But I don't think it would necessarily mean you have to have a whole ward built at that air change rate. What you would have to do is build a sufficiency to give you space if you're having a peak of patients who needed that 10 air changes. So half of your ward could be built like that.
I appreciate one can become too detailed about this, but I have heard quite a lot of evidence about the way the Schiehallion unit in Glasgow was designed and used. And again, the evidence indicates that certain periods of time, children remained within a specific room, and at least some of the rooms were isolation rooms designed to a specification which, broadly speaking, met the specification in Table A1. But I also heard evidence about the desirability of allowing all children to play in the corridor, for example, and interact with other children and indeed their parents. Now, if one, starting from scratch, was designing a patient ward for the pediatric cohort treated in the Schiehallion, who might from time to time be neutropenic, would you consider a neutropenic patient ward to include the whole space, including the play area, maybe the other facilities for interaction with other children and parents?
So I think if you were neutropenic as a child, you're unlikely to be mixing with other children. You're unlikely to be mixing with other children because you're at risk of infection. So by the very nature of having a low white blood count and being prone for infection, you'd probably be quite unwell, but you would also be restricted to your room. And therefore, whilst I fully agree children should have space to play, it's unlikely that would be in a communal area. And I feel I'm creeping now onto building engineers' advice and specialist advice about what size of ward you would want to have with that positive pressure. And I do think eventually 2A did build it across the ward so that they had the flexibility. But I don't think you would be looking for children to be mixed when they're neutropenic. But and it's something that should have been, in my mind, easily thrashed out at design stage of the building.
So just to be clear, I think your primary point is that the users and the designers should be really clear about this at design stage, along with the patient pathways.
Yes.
And so if we have clinical output specifications that have patient pathway, but don't say which bits in neutropenic ward, that's probably a gap that, to be fair, the engineer should probably have spotted, but it's certainly a gap.
Yes, and I suppose it depends what stage it's at. If it's at the competitive tendering stage, then it costs more money. So if a lower spec has been specified, the question is, why would you want to increase your prices? Because your competitors aren't going to increase their prices. So it's in the specification before you go out to tender. But yes, a good building services engineer should know about neutropenic wards and the requirement. I mean, it's quite clear on the table.
Thank you. Will, this might be a good point to break for lunch.
We'll do that. Ms. McQueen, could you be back for 2:05?
Certainly.
Lisa?